This lecture is over the chapter in your textbook called Endocrine and Nervous Systems. Starting at the very first page of that chapter, we talk about the format of the endocrine system. There are 9 glands that make up our endocrine system, but only 4 of them are actually included in the endocrine system subsection of our CPT manual. And it talks about the 4 that are listed there, are the ones that we deal with in the actual endocrine system section. The pituitary and pineal, it says codes to the nervous system subsection. Pancreas goes into the digestive. Ovaries and testes go into the respective male and female reproductive. Coding highlights. The endocrine system subsection includes 2 subheadings of. So the thyroid gland is 1, and then we get into the parathyroid, thymus, adrenal, pancreas, and carotid body. All of these codes, again, as you can see from that range there, 60000 to 60699, all start with a 6, okay? Your thyroid is a gland that's composed of a right and left lobe on either side of the trachea, just below a large piece of cartilage. Okay, that's your thyroid cartilage. 2 of the hormones secreted by our thyroid gland are T3 and T4. The thyroid gland normally produces 80%, of T4 and 20% of T3. These hormones are necessary to maintain the normal level of metabolism for ourselves and our bodies. Thyroid function tests assess the levels of hormones produced by our thyroid within the thyroid subheading in your CPT. There are categories, so for incision, excision, and then also removal. So the parathyroids, and there's kind of a small picture here down below, but the parathyroids then are those 4 small, round or oval bodies that are located on the back side, kind of embedded, on the top of our thyroid gland there. When I mean on top, I mean on the surface. These glands secrete the parathyroid hormone. It mobilizes calcium, from our bones into the bloodstream. Obviously, that's necessary for functioning of our tissues and the muscles. And within that second blue box area, the parathyroid, thymus, adrenal, pancreas, and carotids, we have, again, excision, laparoscopy, and other type of procedures. So turning the page, we really go into a lot of A&P. A lot of this chapter is a lot of maybe repetition from A&P or medical terminology as well. The adrenal glands or suprarenal are 2 small glands situated on top, like a little hat, right, on each kidney. I think that's how we learn in med-term. There are 2 parts to each one of the adrenal glands, and so the outside and the inside, really. The cortex is that outer area, and the medulla is the inner portion then of the adrenal glands. They talk about the thymus. You can read about that. The pancreas. You can read about that. Okay, again, that codes into the digestive system. The carotid body, you can read about that, and then also all endocrine glands then, are ductless. That means they secrete hormones directly into the bloodstream rather than through ducts leading to the exterior of the body. Exocrine glands, so see the difference there. Endocrine is within, exo is out. Exocrine glands then send their secretions or chemical substances into ducts, and then it goes to the exterior or out of our bodies. Examples of exocrine glands are famous, for sweat. Sweat glands. They go to the outside of our bodies, right? Mammary glands for milk-producing, mucus, salivary, lacrimal, our tear duct glands. All those are exocrine, So know the difference and pay attention. It's just slow reading there with endocrine and exocrine. So looking at the thyroid gland, incision and excision, they talk about a thyroidectomy. The term thyroidectomy can apply to the total removal of that gland, A removal of one or part of one of the lobes, Yes, that would be a lobectomy. Or the actual isthmus, which is the part in the very middle, the little strap in the middle that connects, both of the 2. So the whole rest of that page there under the thyroid gland incision and excision really talks about thyroidectomies, why we do them. They talk right away first about maybe treatment of various thyroid disease. Maybe we have nodules, maybe hyperthyroidism, cancer of the thyroid gland, enlargement or goiter, swallowing, and breathing type difficulties as well. So they talk about the partial thyroid lobectomy, okay, and the codes that we would use for that. The total thyroid lobectomy, okay, and how we would do that with or without the isthmus, okay, in the middle, that middle strap that connects. And then a regular total thyroidectomy is discussed after that as well. And I kind of have a note on my page right here that we do have a thyroid video in the content for you, the Nucleus Medical Media right here for thyroid surgery. Okay, you can see that on your screen. I have a few videos shown here. If you turn the page, we talked about the parathyroid. There's just a small little clip about that at the bottom you can read. Then we get into the nervous system. So that everything right there was just endocrine. Okay, very short and sweet. Then we get into nervous. So the structure and function of the nervous system, back to A&P, back to medical terminology class. A lot of this is repetition for you, which is good. Okay, the more you hear it, the more you remember it. The actual split between the central nervous system and the peripheral nervous system and what those entail. I make notes in my book and in my margins here. For central is, your brain and spinal cord. And peripheral is those spinal nerves, peripheral, anything that breaches or fans out from that spinal cord, okay? So again, a lot of this is anatomy and physiology. We see the picture there on the next page. Your brain and spinal cord in that orange area, that is your central nervous system. And then anything exterior, anything branching out from that is our peripheral. You can see that in the green. Go right to code assignment on the next page. Here it says the nervous system subsection. These codes report procedures performed on your brain, spinal cord, nerves, all associated parts, okay? The subheadings are divided according to anatomic site, whether it's part of the brain or the spinal column or a type of the nerve. The subheadings are further then divided down based on the type of the procedure as we whittle this down to get that correct code. The codes report services on both the CNS or central nervous system and the peripheral nervous system as well. To assign the correct code, that's always, good information for us as starting out here in coding. You must first know the purpose of the procedure because many of your code descriptions indicate the condition responsible, okay, for that procedure. Examples include abscess, cyst, hematoma, foreign body, tumor, seizure, aneurysm, vascular malformation, rhinorrhea, hydrocephalus, spondylolisthesis, herniated disc, meningocele, nerve pain, spasm, neuroma, neurofibroma, in addition to the technique used for the procedure. Many of the procedures require radiological supervision and interpretation as well. Next, the coder must know the location of the procedure within the skull, meninges, or the brain. So we start first with skull, meninges, and brain. You can see the headings here. We have punctures, twists, or burr holes. One word that we deal with there is trephination. So it talks about injection, drainage, or aspiration. Twist, drill, burr hole, or trephine. They deal with conditions that may require holes or openings to be made into the brain, and this is to relieve things like swelling, pressure, okay, from the swelling, insertion of a monitoring device, placement of a tube or shunt, injection of contrast material, or to drain a hemorrhage, okay? A ventricular puncture requires a puncture through the top of the portion of the skull. A cisternal puncture is an approach at the base of your skull. And then it says to accomplish many of these types of procedures, a twist or burr hole is made through the skull. It leaves the skull intact except for that small opening or that hole where we can gain access. Okay, that's an access point is what that is for us. So craniectomy and craniotomy. I want you to read through these really, really careful. It says, as in other subsections, many procedures are bundled into one craniectomy or craniotomy code. You have to be really, really careful. okay, for unbundling type reasons here. And it really goes back to your, make sure you're focusing on your medical terminology. We know ectomy, okay, is a removal or an excision, right? Okay, and otomy or otomy is the process of cutting into, okay? So there's nothing being taken out or off, okay, and tomy, but there is an ectomy. Ectomy is removal or excising, taking something off. So you have to make sure we pay attention to those, and just your descriptions there and definitions can help you. Grafting, it talks a little bit about that quick before they get into surgery of the skull base. It says when craniectomies are performed, it's not uncommon that additional grafting is required to repair that surgical defect caused by opening up the skull. So the grafting procedures are reported separately in addition to the major procedure. Of course, we put that first. If you look at the next page, we have a couple of bold terms here. We have the approach procedure and the definitive procedure. And that whole paragraph, it's a pretty good lengthy paragraph. I just kind of have that starred and highlighted that this is really, really great paragraph for us to read. The approach procedure is a method used to obtain exposure, okay, of a lesion. And they give us examples there. The approach procedure is the anatomical location. The definitive type procedure then is what was done to that lesion, and they give us examples of that. If one physician did both the approach and the definitive procedures, both is going to be reported there for us. For example, a neoplasm is excised at the base of the anterior cranial fossa, extradural, using a craniofacial approach, to the anterior skull base. Sounds hard, right? And scary. This would be reported with the code 61600 for the procedure. Definitive procedure, extradural excision of a neoplasm. And 61580 is the code we would use for the approach. Approach procedure, craniofacial. Because two procedures, both the approach and the definitive, were performed by that same surgeon, both codes would be reported for that doctor, 61600 and 61580. The most resource-intensive procedure would be listed first without a modifier, okay, and they're saying that would be our definitive code. And the lesser procedure, which is the approach, would be listed second with a modifier 51, multiple procedures added to it. Really, really good there, okay, to help us. Codes in the repair and or reconstruction, another paragraph down. It says, these are, this type of repair is the last step of reconstruction. It is reported separately, but only if it was documented as being very extensive. Okay, if it's extensive, then we would put a code there. If it's not, if it's more normal, okay, then we would not bill it out separately. This last paragraph before the next purple heading here is really good too. I kind of have a star and a highlight. That's a great paragraph there as well. I'm kind of watching my time here, but I'll read it through really quick. At any point, one or more surgeons may be performing distinctly different parts of all of these complex procedures. You might have multiple people in there. When one surgeon performs the approach and another surgeon performs the definitive procedure, and yet another surgeon performs the reconstruction or repair procedure, each surgeon's services would be reported with the code for the specific one that he or she did. Again, if one surgeon performs more than one procedure, each one is reported separately, adding modifier 51 to the secondary procedures. For example, if one surgeon performs the approach, the definitive, and the reconstructive, all of it, okay, the services are reported and they give us in line there. The most resource intensive, or the one that would be most expensive, is going to be first, and then the other ones fall in line and they have a modifier 51 on them, as you can see. So aneurysm is listed there, cerebrospinal fluid and shunts for those, CSF shunts. The spinal cord is next. Knowing your posterior, anterior approaches is going to be huge. They talk about a lumbar puncture on the next page. Again, most of this is just reading. I'm going to get cut off here. None of it is anything that we go through in too much depth, except for right at the very end of the chapter, the neuroplasty, where they talk about carpal tunnel release. That would be a good area for you to review on your own as well. Okay?